Good evening. Thank you guys so much for joining us. I know we have tough competition with the bar over there, but I think it'll be a good investment, and I think we're going to go through quite a bit of information. So ultimately, I just wanted to first introduce myself. I'm Jill Luken. I'm with JA Counter, and then Katie Cole is going to speak with me. We're going to kind of tag team the presentation. We are part of the Employee Benefits Division or Department at JA Counter, which is just up the road. And we work with municipalities, public sector, and private sector with benefit packages and kind of helping determine what the best option is, design strategy, long-term and short-term. And then also just stay up to date with education and compliance and everything for our clients and ourselves. And a big thank you to Bakke Norman for inviting us to be here today. It's quite an honor, and we really appreciate it. On the agenda, slide is not in your booklet, but we did just add a quick slide. We have a lot to cover, and we're going to go really fast. So in the booklet, you've got your PowerPoint slides, and just know that if you guys have any questions or if you want to talk specifically about something that we bring up, maybe on one-on-one or somebody at the village wants to or the city, you guys, we have our cards and our information's in the booklet, so please feel free to reach out. But we're going to talk about kind of the state of healthcare today and some of the increasing costs, about wellness and some buzzwords, transparency, value. Wellness is a huge buzzword right now. And then we're also going to go into just some strategies that we've implemented at different private and public sector alike, and then some ideas on ways to maybe help with your budget, and then also end with legislative updates, which may or may not happen. So it's a huge part of our world today, but we understand that without knowing exactly what's going to fall into place, it is a law right now, so we are paying a lot of attention to it, but ultimately there are a lot of changes coming our way. Who is JA Counter? We do not do countertops or accounting, and we were already asked that today, so we are a benefits firm. We also have other divisions, but a few of you guys are probably familiar, but ultimately our goal is to kind of make a difference when it comes to your healthcare costs, being part of the solution, focusing on strategy. We try to have extremely trained staff, and then education, which is kind of where this fits in. We do a lot of educational opportunities both for employees and boards and community. So just a little bit about us. And then this is my picture right before I hand it over to Katie. I mentioned there's a ton of information that we're going to go through, and we're going to go through it really fast. So you can make notes on the slides. You can talk to us after. We can get you the PowerPoint if you want it in an electronic format and to share it with other people. But ultimately, just know that we feel it's really important to have knowledge, because I think at the end of the day, when you're decision making and when you're negotiating and when you're looking at making changes, the more information you can have to make educated decisions, the easier it is for change, which Tom already alluded to we are in the midst of right now. So I'll give it to Katie.
And I'm going to have trouble with this because I don't like to stand in one spot. I'm a mover. But I just want to give you a little bit of background on healthcare costs and kind of where we've gotten ourselves to. Annual healthcare spending for the average person has risen over $6,000 since 1999, which means for the average family of four, healthcare costs are totaling over $40,000 a year. And that's a scary number. It's not really so much the number that we need to focus on, though, as it is our utilization as consumers of healthcare. And are we paying our fair share? I guess that's the question that we need to address. Taking a look back historically at health plans and how they've changed over the years, in 1970, some of you may remember what a health plan looked like. It was a catastrophic plan. It probably had about a $200 deductible and $1,200 out-of-pocket maximum, but it was strictly there to cover the large claims. You probably didn't have copays on your office visits or your prescription drugs, or 100% coverage for preventive care. And now today in 2011, not today, but if we were to adjust for inflation to bring us up to today, the average health plan should have an $1,160 deductible and almost $7,000 as an out-of-pocket maximum. Now, you and I both know that we're not there with our health plans. We have really not kept up with inflation in changing health plans so that consumers take on a little bit more responsibility. and pay a little bit more of the share. To put this into perspective for you, does anybody in this room happen to know what the cost to have a baby was in 1970? Just a guess, or maybe somebody had a baby in 1970, and if you haven't heard this presentation before, you can raise your hand. Any guesses? 5,000? It was actually closer to 500. So about $525 was the average cost to have a baby. So good guess. But yeah, but that shows you though today where our head goes immediately is thousands of dollars. And in 2011, any guesses as to how much it would cost to have a baby? 20,000, get close. I actually have a bill at home. I had a baby on December 15th of 2010, and it is $12,600. That's a normal delivery, so without complications. Of course, they can get a lot higher. So as you look at the health plans today, realistically having an out-of-pocket exposure of about $2,500, we're really not paying the share that we were paying back in 1970 for something like that. So again, just paying our fair share. Now, healthcare, how have these costs gotten to where they are? Why do they keep rising so dramatically? If we could just point our finger at one thing and fix it and just make the whole problem go away, that would be nice. That would be beautiful. We wouldn't have a job, maybe, but it would be really nice. And the fact of the matter is there are a lot of different factors that are attributing to rising healthcare. We'll just take cost shifting, for example. Some of you may know that Wisconsin just happens to be one of the lowest reimbursed states in the nation for Medicare reimbursement. And Badger Care and Wisconsin High Risk Program and Medicaid all follow suit with Medicare reimbursement. So oftentimes when someone that's covered under one of these programs goes in for care, the reimbursement isn't even coming close to covering the cost of care. So who pays that additional amount? Well, somebody has to. And really what happens is that amount then gets shifted into the private market, thus increasing your premiums. So those types of things, that shifting is going on all of the time. Legislation, every time a mandate is passed at the federal level, at the state level, our premiums go up. That has a direct impact on our premiums. So all of these things around this pizza here show you some different areas that are just going to push those health costs up. Lifestyle, we'll look a little bit more closely at that. The decisions that we make as individuals, whether or not to use tobacco, how much we weigh, how much we exercise, how much we consume alcohol and drugs. Those are all decisions that will directly impact the amount of health care that we're going to need in our life. This slide is powerful and actually a lot sad. Obesity has become an epidemic in America. And this slide takes you through the years looking at our country. In 1995, you can see that it's all pretty much blue. The western half of the country is a little bit lighter blue. And for purposes of this slide, we're going to consider somebody that's obese to have a BMI, a body mass index, of over 30, or a 5'4" individual to be over 30 pounds overweight. So as you can see, in 1995, the western half of the states had about between a 10 and 14% of their population being obese. In the eastern part of the country, the states had between 15 and 19% of their population being obese. If we fast forward to 2005, now all of a sudden that blue goes away and it's replaced with some yellow and orange colors. Not a good thing, because that means that the percentage of the population in each state has actually risen. These slides are in your folders too, so you can see them a little bit closer. But bringing it up to 2010, the most recent data that we have, now the red has entered the picture. And so for a lot of the southern states, over 30% of their population are considered to be obese. So again, just an epidemic that's spreading and something that's drastically affecting our healthcare costs. So what are we going to do about it? As employers, what can you do to make a difference and to help your employees with their lifestyles, and ultimately to help your bottom lines, your healthcare cost expenses, and your productivity? Well, wellness, and Jill mentioned that at the very beginning. It's a buzzword right now. Employers are discussing wellness in the workplace more than they ever have before. That includes all industries. That's public, that's municipalities, that's construction and manufacturing and service industries. Across the board, everybody's talking wellness right now. And there's a lot of reasons why they're looking at it. Some of what, attracting good workers. Employees are looking for wellness when they look at prospective employers. Reducing turnover, reducing healthcare costs, and improving productivity. Let's take a little bit closer look at improving productivity through health promotion in wellness programs or health promotion. Employees are just more likely to be on the job and performing when they're physically and mentally healthy. That should come as no surprise. And investing in wellness programs on the work site are actually likely to yield greater returns from an increased productivity standpoint than from a medical care cost savings. Reducing absenteeism. Investing in health promotion has a dramatic impact on your absenteeism and disability rates within your workforces. Just looking at a study done by the Healthy Workforce Partnership for Prevention program, a fitness program in a police force actually reduced sick leave by an average of 4.8 days per year. Back injuries, common across, again, all industries, in overweight and unfit workers is a major cause of work lost time and disability, and very, very costly to a company. JA Counter performs a local benefits benchmarking survey every year where we go out and survey local employers on what they're doing in the way of their benefit packages and what kind of things they're implementing in their company, what opinions they have on legislation, and what's keeping them up at night. And employee morale for the last 3 years has been cited as one of the top 3 areas that's keeping management, and again, across all industries, up at night. So what can we do to improve employee morale? Well, wellness and investing in health promotion is one way that we can do that, making employees more loyal to their employers, having a better attitude, making your workplace someplace that your employees want to come to every day. Employees are asking for wellness as well. They want to feel better and have more energy. We all do. That should really be not a shocker to any of us. We want to reduce stress and lose weight and live longer, higher quality lives. And we all spend a big chunk of our day, our time, at our place of employment. So what better place to give your employees the platform, the tools, the resources to get healthy? According to this graph up here, you can see, and a lot of the wellness programs that we see at JA Counter really do focus on smoking, overweight, physical inactivity, low fruits and veggie consumption, and that's a good thing because this graph shows you that in men and women between the ages of 35 and 69, when all 4 of these are present, smoking, overweight, physical inactivity, and low fruit and veggie consumption, the probability of dying dramatically increases. You're over 4 times more likely to die than if none of these risk factors were present. If wellness is something that you're interested in implementing within your organization, I highly recommend that you work with your broker or your health insurance carrier because there more than likely are a lot of tools, free resources available to you. And it's important that your wellness program tie in with your benefit structure and that it fits your organization. So we see just across the gamut, employers starting with a walking program or maybe a smoking cessation program, all the way to the other extreme now where we're seeing more and more employers tying wellness programs into their benefit structure. So if an employee takes a health risk assessment and participates in a healthy living program, then they can get a lower deductible on their health plan, or they can pay less in premium every month on their health insurance. So that's becoming more of the trend, is to actually maybe using the carrot or the stick approach, depending on how you want to go with it, but incenting your employees to participate and to really get engaged. This slide up here shows you JA Counter has really made it an initiative for 2012 to get wellness out there. So if this is something that you are interested in taking advantage of, we have created basically a wellness in a box, a pre-made wellness program. We did all the administrative work because we recognize that you as employers, as business people, just don't have the time necessarily or the resources or the money to create wellness and to put it into your organization because it does take a lot of time and it does take money. So we've taken the administrative activities off your hands and put this together, 4 quarters of wellness for 2012. And essentially all you would need to do to take advantage of it is to let us know, and we would send you the information and you could distribute it out to your employees at no cost. So again, let us know if that's something you want to talk more about. It's available to you. And with that,
Katie's taller than I am, so I have to move it down. So wellness is a huge buzzword, but there's obviously more to increasing costs than just us taking care of ourselves, especially for those of you that have less than 50 employees on your health plan. Some of you may have 3, some of you may have 25, some of you may have 50. You're pooled if you're in the private market. So, you guys may all be at different spots with your plans and the municipality side of it, but ultimately we've worked a lot with with the transition from the state plan to the private market. But there's also other buzzwords that are consumerism, transparency, and value. And when I talk value, it's kind of interesting. We have a slide, and I didn't include it in here today, but the cost, people spend more time evaluating the value of a car or a pair of shoes even than they do on the value of their health care. So when you think of your well-being and your livelihood and how long you're going to live, it seems a little backwards, but ultimately it's always just been there. You've always had health care, and now more recently people are starting to talk about consumerism, transparency, and the value of care. Ultimately, the outcome of being treated, your diagnosis, the cost to be treated is ultimately what the value of your health care is. This slide we use a lot from an educational standpoint, and it talks about the different costs related to a certain diagnosis of where people are getting treated. This is in your packets, and I know it's a little hard to see probably on the screen with the colors. If we just take pink eye is a perfect example. It's $50 if you went to a minute clinic or convenience care clinic on average for that visit, for a pink eye visit. But oftentimes, if that minute clinic isn't open or you don't have time to get there and you end up just running to urgent care, that same exact visit for that same exact diagnosis would be $102. So that $52 is getting shifted, whether it's to the plan, if that person maybe just had a copay, or if they're on an HSA or an HRA style plan, they're going to feel that difference. So having this education at their fingertips truly makes them better consumers. Even, I mean, you can take it a step further and say if they ended up going to the emergency room in the middle of the night for pink eye, now that same visit just went up to $370 on average. So you can see that the cost of care clearly changes depending on where you're seen. The next thing that's a big topic, especially with transparency, is prescription drugs. Now, there's a lot of talk and controversy and everything with pharmaceutical companies and prescription drugs and the cost of drugs. But the big questions that I feel are important and we feel are important are they as safe as brand name drugs? Are generic drugs the same? Are they exactly the same? And a lot of people hear a lot of different answers to those things. This chart I'm going to show you also. So these are 3 drugs that treat the same thing. And then there's your federal guidelines of what considers a drug to be A-rated. So in this example, you see there's the treatment, the care schedule, and the outcome is actually the same. And from a regulation standpoint, they are all considered to be A-rated. Now, I don't know which one's the generic and which one's the brand, but ultimately they aren't the same. And we can identify with that the lines are not exactly the same, but they are as safe. And that's where the research and development and the statistics come in when they do all of the analysis for formulary and non-formulary if you're on a private plan or if you're on an HSA plan. So this type of information is really valuable from a consumerism standpoint if you know. And a lot of people don't know. If you go in and you ask, can I ask what my generic brand or my generic drug is rated? They can tell you at the pharmacy. It's an A-rated drug. It's a B-rated drug. You can talk to your doctor about these things. Here's a few more examples from the pharmacy, just because it is such a big prescription drugs are a very high cost to plans. If we take it a step further, we'll compare. You look at ulcers. Ulcers get diagnosed, and then they need prescriptions to be treated. Nexium. When I say Nexium, a lot of people think, okay, the purple pill. Or when I say Lunesta, immediately some like butterfly flew through your window and landed on you, and you slept wonderfully that night. The purple pill, 20 milligrams, is $162 for 30 days to treat the ulcer. If you take the generic version of that, it's about halfway down. Omeprazole, 20 milligrams, it's $14 for a 30-day supply. So ultimately, if those drugs were both rated A drugs and they were as safe, Dr. A might prescribe you prescription Y, and Dr. B might prescribe you prescription X. But ultimately, if they're A-rated, they're going to follow that same structure. So I think it's just bringing us to that step of consumerism and understanding these differences, which is a huge part to helping the budget and the actual cost of your care. Because ultimately, those renewals every year can be controlled if the knowledge is there on the consumer end. And then ultimately value. a big drug that gets used a lot, and the simplest way to kind of talk about value is cholesterol management. And in a study where the 44% LDL reduction was the goal, you've got your main drugs. I mean, these are drugs that you guys have heard of. They're possibly being used, more than likely being used on your plans. You go Lipitor at 20 milligrams, it's $120. You go simvastatin at 40 milligrams, and it's $12. Ultimately the same results. So the value obviously increases when the cost of the drug decreases. Now, regardless if you're on a copay plan or if you're on an actual HSA, HRA, Medicare Part D, or the employer's picking up that portion, those costs are still getting charged to the plan or the member. So ultimately, just the idea of consumerism, transparency, and value are so important right now as we transition in this paradigm of uncertainty and change, as Tom referenced quite a bit earlier. So Katie's going to kind of talk a little bit about strategy.
With the overwhelming share of the health insurance premium going back out the door to pay for healthcare costs, so your physician services, your prescription drug costs, MRIs, CAT scans, inpatient stays, all of that, it is really critical that we focus on the larger piece of the pie, the 85%, because for every $1 we pay in health insurance, 85 cents goes back out the door to pay for directly for healthcare costs. So when we're designing our benefits for the organization, it's important that we think about that and we look at how we can impact that big piece of the pie and enable monetary control over your healthcare budgets for the long term. And that's the key. We're really talking more of a long-term strategy when it comes to your healthcare plan, looking 3 to 5 years down the road. One strategy that employers are using to focus on that larger piece of the pie is a health reimbursement account. There may be some people in this room that are familiar with that concept or are covered under such a plan design. But what a health reimbursement account is something that usually works in conjunction with a high deductible health plan. As you may or may not know, the higher the deductible on the health plan, the lower the premium. So the more exposure that you take on in your plan, the more premium savings there is to be had. So what employers are doing is increasing their deductibles, taking a portion of the premium savings to help employees pay for their out-of-pocket expenses. So it's giving the employer a little more control over their plan. There's a separate HRA, or health reimbursement account, then set up for each plan participant. For those of you that are a little more visual, this is what it looks like. It's a bucket of money that employers are setting aside to help employees with their out-of-pocket expenses. That those employees dip into that bucket and take the money out to help them with claims that are subject to the deductible. Any money left in that bucket then at the end of the year, depending on how you set your plan up, can be the employer's. The employer keeps those dollars and puts it towards the next year. There are tax advantages to having a health reimbursement account plan. Employer contributions made on behalf of the participant are tax-free. The deposits are going to grow tax-free, and funds can be used tax-free for any eligible qualified medical expenses and retiree premiums. Another approach that employers are using, organizations are using, and more of you may be familiar with this, is a health savings account. So what a HSA is it's a high deductible health plan, there for the catastrophic occurrences, kind of going back to that 1970 health plan mentality we talked about earlier, and it's coupled with an investment or a savings account from which the employee can withdraw money tax-free for qualified medical expenses. The high deductible health plan portion of the HSA is regulated by the IRS, so it has to look and feel a certain way. And what the IRS says is that it must have a minimum deductible for a single person of $1,200. Cannot go lower than that. And it must have a minimum deductible for a family of $2,400. These amounts are indexed every year for inflation. Annual out-of-pocket expenses cannot exceed $6,050 for a family, or $12,001 for a single, or $12,100 for a family. The health savings account is actually something that's set up at a financial institution. Each employee has one, and it works very similar to an IRA. It's designed to mimic the IRA, really. And it's the only savings vehicle out there that has a triple tax advantage. So that's a pretty big deal. Contributions to the health savings account can be made by the employer, the employee, or a combination of both. But either way, contributions are tax deductible. Interest earnings on the HSAs IRAs are tax deferred, and withdrawals that employees make out of those accounts for qualified medical expenses, which can include things like anything covered under your health plan or dental care, vision, LASIK surgery, contacts, orthodontia, all of those things can be paid for with HSA dollars, and withdrawals are tax-free. So there's the triple tax savings. The account's owned by the employee, and contributions, whether they're made by employer or employee, are 100% vested from day one. The beautiful part of the HSA is that funds roll over from year to year. So it does encourage consumerism. Employees will think twice about spending those dollars when it's their own money that we're talking about versus the health insurance companies. We are also seeing a lot more creativity when it comes to benefits design and benefit strategy. Many employers out there are now taking the HRA that we talked about and the HSA and layering them or combining them within the same plan design. So it's a little bit more of a creative way to save money, to actually reduce your fixed expenses, the premium that you're paying into the insurance company, take on more exposure, and design it in a way that looks very attractive to your employees. So a lot of different benefit design strategies going on. Work with your broker to figure out something that's going to work well for your organization. The last approach that I'm going to talk about is a defined contribution approach. And this isn't something that's necessarily new as far as a defined contribution goes, because employers have been doing that for a long time, where they say, we'll pay $250 for every employee in this group to put towards our health plan. We're just going to set a flat dollar amount. The difference, the newness comes in, is that now employers are saying, well, we're going to set aside X amount of dollars this year for our employees to use for health insurance, and we're going to offer them a menu of plan options. And insurance carriers like Medica and Health Partners are responding to this need and coming out onto the market with some pretty cool products that are allowing employers to do just that. So it's giving employees this flexibility that they're loving, and employers have the ability to set their budgets and set them for, again, that 3 to 5 year strategy, so they know exactly how much they're going to increase that contribution by every year. So that menu of plan options has gone over really, really well, and that's a defined contribution approach. So we'll look at that in a little bit different light. In today's world, really what happens is the employer controls the cost shift when renewal comes around and the company, the municipality, receives an increase of, say, 10%. Now, in the current situation before the renewal, let's say that your municipality has a total health care spend of $560,000. $400,000 of that, which are employer, $160,000 which represent employee spend. Renewal time comes, 10% increase to the plan, hypothetically. Now the employer decides, well, due to budgetary constraints, maybe they don't decide, but their hands are tied, they can only take on an additional $20,000 going forward into the next 12 months. The rest of that is shifted to the employees. And basically the employees are stuck because they have this plan design here and they're getting this increase in premium that they need to put towards it. So there's really no other options within the plan. Looking at the defined contribution strategy that we just talked about, now the employee gets to control that cost shift, which is pretty powerful. So in the current situation, we have the same total healthcare spend of $560,000. Renewal time comes around on January 1st, and the plan receives a 10% increase. Now the employer says, well, we're only going to be putting $420,000 towards health insurance this year. The rest of it is going to the employee. But the employee has now the flexibility and the ability to react to that premium increase. So they have this menu of plan options that they can choose from. And they can now go and pick a plan that maybe has a lesser premium to help them with that renewal increase, and a plan that's still going to work for themselves and their family. So again, that flexibility that employees really love. Up until this point in the presentation, we've really talked about what health insurance looks like today, some current benefit strategies, trends that employers are using. But as everybody in this room is well aware, there is this interesting and complex law kind of looming over us that as we speak is being reviewed by the Supreme Court. So depending on the fate of that law, everything we talk about could really change. But even if nothing changes, even if the Supreme Court deems the law to be constitutional, there are still going to be, regardless of what decision is made, there's going to be things that you as employers need to do to prepare and to react to that. So that is where Jill comes in. The next slide. So hopefully
Hopefully this makes you smile just a little, whether that's us, the them, delivering a 10% increase or not. Either way, guidance is extremely important as you shift into the next few years of healthcare. I think that we as brokers, and I know that a lot of the other fellow brokers in the area have focused some energy and attention on just keeping this information as up to date to the employers and the municipalities in the area as we can. I think it's going to help guide your strategy, but I also think that it's kind of just, it's good to know about it, but it's not necessarily important to think too hard until we have a few more details. Katie mentioned the Supreme Court, and unless you're living under a rock, you're probably aware there is some debate that just finished up, and there's going to be a decision hopefully by June or July on whether or not the part of the law that states that if you do not have health care, you have to pay some type of fine or penalty or tax, depending on who you're talking to. That decision, whether that's constitutional or not, should be out in June or July. In the event that it isn't constitutional for them to require someone to pay a fine or a fee or a tax for not carrying coverage, the next step is, does that make the entire law unconstitutional? And that is to be determined. We have no idea what's going to happen. If you were to ask me next March, I'd probably have a little bit more to say on where we're going and what's going to happen. But today, it's a little hard to say if this bill, how much of it's actually going to go into place. But as of today, it's a law. And some of the pieces of the law have already gone into effect. So we are working on things as they come. But as you'll see in a minute when I start going through these slides extremely fast, because you guys have the slides, the information's in your packet, but ultimately, rather than spending a ton of time on it, it's easier just to kind of run through, and then you guys can ask questions if you have them. But the first one to talk about is non-discrimination testing, which may or may not have been on your radar last year's renewal. About 3 days before it was going to go into effect for a majority of businesses, it got delayed until further regulation. But it basically means that nobody is able to have different waiting periods or different contribution amounts on the same plan. So there was to be no discrepancy between, in your guys' case, maybe the internal office folks and the plant guys and the police officers. Everybody was going to need to be treated exactly the same, which for most people wasn't going to be an issue, but for a handful it was. W-2 reporting, I believe, and I asked, everyone is under that 250 employee mark. We are not, as under 50 lives on your plan, you're not going to have to record any W-2, the cost of care on your W-2, but that was something that was in the bill as well and is going into play for plans that have more than 250 people on their insurance, or more than 250 W-2s that go out. Uniform explanation of coverage. For most of you, if you're on the state plan, if you're working with Health Partners or Medica or Anthem or any of the private carriers, this is likely going to be done for you, but as you can see, it really wasn't talked about in the last month, and that's because it got delayed. This 4-page summary of benefits that was going to be required had specific requirements like the size font, single spacing, what it needed to entail. It had to be 4 pages. It didn't get pulled together, and then it got delayed till further regulation. But in the event that all this comes through, these things will have to happen. And ultimately, as a smaller plan, if you have less than 50 on your plan, or even if you have more but you're not self-funded, we'll be relying on the carriers, hopefully, a lot for some of this stuff. But that's to be determined if the carriers come out with it. Upcoming mandates. I'm not going to spend a lot of time on the fees and the taxes, but I wanted you guys to have the information, so it is in there. Ultimately, the fee that's in this slide is for the health insurance carrier, but we try to bring it up kind of so it's on everybody's mind. It probably will have the trickle-down effect. Ultimately, if the carrier has to pay more, then they're probably going to have to increase the premiums to cover those fees. And that's effective this September 30th as renewals come after the September 30th. A flexible spending account is FSA for short. Currently, there's no limit on an unreimbursed medical account. So you can have dependent daycare, unreimbursed medical, and then you can also have your premiums pre-tax. So it's a tax sheltering vehicle. As of your FSA renewal this year, changes will need to be made. Some of our groups have already had to do this if their renewal was February 1st or March 1st, because the employee is on a tax year. So they have to have this changed in their FSA before 2013's tax year. So if your FSA started February or March, if it doesn't start until next January, if it doesn't renew until next January, you're fine. But if it already renewed, this is something that you'd want to talk to your broker about and make sure that you guys are under that limit for that FSA. Employer notice requirements may or may not pertain. Basically, I'm going to talk about exchanges at the end, but the existence of a healthcare exchange and the eligibility or the potential eligibility if your coverage is deemed unaffordable are things that are going to need to be posted by next March. So if it's constitutional and if we have the law and if the presidential election doesn't flip things and if this could happen a year from now, you might have notices in your office. 2013, there is a tax that we're kind of yet to see how the guidance is going to be, but on higher income earners. So there are going to be employers that are going to be dealing with how to handle that on the payroll end. The perfect storm. I use that term mostly because the conceptual nature of what could potentially happen in 2013 is going to be very interesting. If there isn't a requirement to have insurance, or there isn't a fine to have insurance if you're not carrying it, so you can go uninsured if I'm a healthy individual and I don't need insurance, yet I have the opportunity to get guaranteed coverage. So guarantee issue, that means I cannot get turned down, and they cannot decline any pre-existing conditions. Ultimately, we could, depending on enrollment strategy and depending on guidelines that surround enrollment, I could go as an employee uninsured because I don't need it and I don't want to pay for it. Even if I only have to pay 10%, I don't want to pay for it. And then I can get that money in my normal paycheck and use it as disposable income. And then I can get diagnosed, and then ultimately I can have a situation where I have an open enrollment and I want to go on the plan and you can't decline me and I have no pre-existing conditions. And then the plan is picking up the cost but hasn't received any of the premium for that. So there's this concern of how is this all going to play together and what is going to get put into place to protect the enrollment. Because if they can enroll whenever they want, there's, the good citizen and the idea is that everyone will have coverage and it will be affordable, and that's the goal. But ultimately, what is it going to look like? And that's what we don't know yet. Pay or play, there's 2 slides on this, and again, you guys have them in your packets. But if you have less than 50 employees, you will not be penalized for not offering coverage at this time, the way that the bill stands right now. There's no penalty. Again, that's full-time equivalent. So if you have part-times, you have to take 2 part-times, make them a full-time, and now if you're teetering on that 50 mark, there's numbers and, the mathematical side of it that you can look at. But ultimately, understanding the regulations, I don't think we're going to see them for a while. And then considering kind of the employee relations side of it. If for some reason, from a budget perspective, for any reason, you're not going to offer care because you're under that mark, you're not going to have any penalties or fines, the employees, in the event this goes through, will have an option to go through the state to get their insurance. What does that look like from an employee attraction and retention standpoint when benefits are very important? The next one is you may offer coverage, but if it's considered unaffordable, which again, parentheses, that's to be determined, and there's some more information in here, but if it's unaffordable, you may end up paying a penalty for them to be going to the state to get their coverage because it's unaffordable. So a lot of things are changing and moving, and it's all an if and if and if, but it's still important to know that these things are out there. So in July or in November or at your renewal in January, you're aware and you can look back and say, oh, I think there's some things that I should think about. Automatic enrollment is just for groups that have over 200 employees. So if this goes through groups, and maybe this pertains to spouses, or maybe you're on a board for the county, if you have over 200 employees, you have to automatically enroll everyone. So that was their way, that's helping the participation and creating that requirement to have coverage. But if you're under 200 employees, you don't, and we don't know. Right now, people can waive if they have an option through someone else, or maybe if both teachers work at, or if it's teachers and they both work at a school district, one can waive and one can take. So that'll be an interesting. And then the exchanges is the last kind of thing I want to talk about. And I think it's hard. A visual is usually easier. And if I could sum it up on what this exchange may or may not look like, I usually use the term Expedia for healthcare, because a lot of people can relate when you say Expedia or Travelocity. You type in your dates and you type in where you're going and they come up with a list, right? Ultimately, this exchange is supposed to look and feel, it's a virtual avenue for people to purchase healthcare through their state in which they reside. So if it's a Minnesota resident, they're going to have to go to the Minnesota exchange versus a Wisconsin resident at the Wisconsin exchange. Each state has deadlines on how much and where they need to be at certain times, and then they have to follow minimal guidelines, and other than that, they can kind of create what they want for the exchange. If they're not created by a certain time and date in 2013, then they're trumped by the federal exchange. Now, unfortunately, we don't really know what any exchange really looks like yet. We do know there's the bronze and the platinum, and there's going to be choices, and I think the idea is a series of questions that'll gear you towards a plan that might fit for you and your family. But without more information, it's really hard to say. We have absolutely no information on cost, which is huge, and one of the main reasons why this exchange was set up, and it's supposed to help make coverage more affordable for the entire nation. So ultimately, if the exchanges come through, Wisconsin recently had made a ton of progress, and you guys may know this, but a ton of progress. We were kind of cutting edge, and a lot of states were watching us, and then we stopped, and we gave all of the money back to the federal government. And we said that in an effort to not show support of the bill, we can't have the federal money. So right, wrong, or indifferent, and whatever your political view is, now we don't have those federal dollars to finish the exchange. So the exchanges started in Wisconsin, but there's nothing telling us if they'll finish it or if we'll end up taking the federal one if the law goes into effect and in the event it's constitutional and the presidential election doesn't change things. So that is about it, and that's how much information we gave you. And I really hope it's not you, because she is on the wrong side of the road. And I don't know if you picked that up, but you're going to get a lot of information, and I know that healthcare can sometimes be really heavy. But if I can advise you on one thing, it's that make sure that you guys are at least talking about it, or at least strategizing what you might do. And you don't even need to do anything at this point, but you guys are having renewals every year. If you're in the private market, or even if you're on the state plan, there is still a renewal, and there are concepts, there are strategies that you can be implementing right now that are actually free that could help potentially kind of tier or change those dramatic increases or not, depending on your population. So you can put your helmet on, and we're done. We can take questions now, but I know there's question and answer at the end. And again, thank you guys for listening. Our information's up here if you want these slides electronically. We're happy to hand them off. Our cards are up here. Our website, I guess I don't have anything else, unless you guys have questions. Thanks.